I invite Dr. Arvind Goregaonkar for his first lecture.
So, Chairperson Dr. Ajay Thakkar, is he around? Asim, Negi, please come. So, infected gap non-linear is not a new entity for the orthopedic surgeon. At the same time, it is one of the very difficult, many orthopedic surgeons will wish I should not get this kind of patient, because not that he is not able to do it, but because the longer duration of the treatment, patient unsatisfaction and everything. So many things are there. So you have to have some method by which you can control this, all the factors, that is the infection, and one is to whatever the gap is there must be breached. A Masquelet technique is one of that technique where you can have a good union. Now this was a 34-year-old male patient with a grade 3 compound fracture tibia fibula 1 year back. When he came to us, this was a condition. There was an infection, and therefore we had to go for the debridement and fixator and a flap. This was a vast deformity at the time of the injury, at the time when he presented to us, ununited fracture. Now, what is important is whatever the dead bone at the ends must be excised, and that is what was done, along with the debridement of the all granulation and whatever soft tissue debris is there, that's done. And that created this kind of gap, which now we need to fill it up. Preferable fixator we use is LRS, and with the help of a LRS, we wanted to achieve a union or stability with that. So the cement block was put, antibiotic coated cement along with the vancomycin and tobramycin. This cement block helps to get the local infection under control. And after the 6 weeks, we went ahead with the bone grafting at that. Although the many times we have found that whatever membrane, Masquelet technique membrane, what we always talk about, may not be well formed, and there are multiple reasons are there. And this patient, again, after the 6 weeks, now we are waiting how long it is going to take, or whether this is going to make it more difficult life for us by not going into the union. So it is, Masquelet technique is not a very simple thing. There are so many factors are there. Original Masquelet technique has a different thing, and most of the time we modified that, and for that we need to know what are the difficulties and what are the problem we face while doing a Masquelet technique. So may I call upon Dr. Milind Chaudhary to present his talk on that.
Respected Chairpersons, Professor Goregaonkar, thank you Bombay Orthopaedic Society for kindly inviting me. At the first, I apologize, it may seem like an inappropriate talk because I'm going to be speaking on limitations of the Masquelet technique. वो तो इलिज़ारोव का छोटा भाई है भाई. So we have to start by thinking which infection is worse. Which of these is worse? So we've come up with an infection severity score which was written up in IJO and also in the textbook on femoral non-unions by Professor G.S. Kulkarni. So this is the infection severity score, and it will help you to decide whether Masquelet is appropriate or not. And then amongst these non-unions, which one are more difficult to heal? So that again is going to help you with the help of this score. It's a guideline. So you look at their tobacco, the shortening, the width, the gap, the fracture pattern, and then figure out what sort of a score you're going to get, excellent or not. So I'll begin with the problems that I faced with the Masquelet. I probably am not doing it right, like Professor Trikha would definitely judge, and Professor Asim would judge. So this is a young chap with this very bad lower tibial gap non-union. We did it right. We did everything right. And I even got, you can see on the right, this nice block. His ankle is short. I got the RIA. I was one of the very early, this is more than 10 years ago. I got the RIA system. We used the RIA. This is the graft we got. He had a precipitous fall of blood pressure. And we managed to pull him out and stuff and pack the thing with the grafts and then see what happens. The graft disappears. And there was a membrane. I tried to do things right. I read Alain Masquelet's original 1986 paper, and thereafter, the graft just disappeared. It's very demoralizing. And then when that happens, you need to have something that's reliable. And the best trusted, reliable method is bone transport. The reason is that you are extra focal. You're doing the corticotomy through healthy bone, through good soft tissues. The soil is good. So when you gently distract it, bring it down, bone forms beneath, and the active compression helps you to achieve the union. It doesn't fail. It doesn't fail. Another example, monomelic polytrauma like this, he had a lot of other problems. We debrided him, repeat debrima, and then we find out to our dismay that he needs one more debrima. So this is where the infection severity score comes. So you can predict and tell the patient, you're going to need 2 or 3 debridements. So the first step of the Masquelet, we did everything right and put him in a fixator. And now look at this. I did my best. A lot of bone grafts from here and there. He's already in non-union for 4 years. So this is a typical scenario. His bone graft sites are exhausted. And we used all this stuff, it's beta TCP, I apologize, I couldn't find the symbol, and bone marrow aspirate. And see what happens, it's not enough. So what this gentleman from China has come up with this, why is the volume of graft you need to fill up a gap of length L? So if the gap is 12 centimeters, you're going to need 12 plus 6 into 12. 6 into 12 is 72, so 84 cc's of graft. Where are you going to get all that stuff from? It's expensive. BMP is expensive. And see what happened. I waited for it to consolidate, so I thought I'll compress it a little bit. No luck. So what do? I performed a bifocal bone transport. How does it work? It works really well. All you need is a little patience, and you need to set up a system where you can take care of these people in the post-operative phase. And it won't let you down, ever. And here he is. At the end of a long sojourn of disappointment, here comes, this is the pot at the end of the rainbow. So something I wrote up, the diamond concept is what Janud is propagated. You take this Masquelet technique and then you add DBM, bone grafts, and BMP. This is the diamond technique. So diamonds are expensive. Rings are not. It's very good to remember that for many of your patients. So depending on how much time I have, so what about a young guy like this with a big bone gap, subacute trauma, 3 months down the line? If you want the Masquelet to succeed, you need to have very good soft tissue cover. So compulsorily you need to have a flap that's put in place and the problems that go along with it. Instead of that, if you just use the Ilizarov, do multiple debridements, cement block, multiple montage changes and small interventions with the Ilizarov, including a WAC, then do a bone transport, and even a 14 centimeter gap will slowly fill up like this and have this patient in 13 months. He was a healthy young lad and very good nourishment, which is why it took him so less. So the cost factor, the Masquelet is physiologically expensive, economically expensive. And if it goes wrong, you're losing a lot of things. And some alternatives. You can do the Ilizarov for this radius gap, and we bring the distal radius out to length, and then you can add a microvascular. We sometimes have the ability to perform this. So that's an alternative to the Masquelet. The Ilizarov is, the microvascular grafting is. And here is this lad with corrected deformities and gap. What happens when your microsurgeon refuses? A case like this, big distal gap, soft tissue loss. They did an MRI angiography and they found that from the level of the knee, there are very few vessels large enough. But the Ilizarov doesn't need the medium-sized vessels. It relies on the collateral formation. And here he is, after multiple debris mod, just skin graft, 10 centimeters of bone transport. He's healed. He doesn't need very expensive, physiologically expensive surgeries. And what about, I'll end here. Last
I suggest just sum up.
Yeah. So taking care of the infection is the key. Determining how bad is the infection, taking appropriate steps and deciding whether the soil in this patient is good enough for a masquelet. Where are you going to get the grafts from? Are they going to work? How good is the soft tissue? And it's better to have many things in your armamentarium. I thank you once again for your kind
Thank you,
invitation.
Milind. Masculine technique, so many discussions going on, but can we improve the result using a masculine technique? So we have Dr. Vivek.
Sitting here. Okay, so without any ado, sir has told regarding the Ilizarov, what is Masquelet? If we'll know the technique properly, then only we will get good results. So first of all, the technique. Remember that you need to do a radical debridement of all non-viable soft tissues and bone. Doesn't mean that Masquelet will do everything for you. You need to do debridement, which is thorough of the bone and soft tissues. Then use a cement spacer properly. Make sure that it overlaps the sides, irrigate so that the heat necrosis does not happen. Soft tissue coverage is a foremost important thing. That's going to give you the blood supply to that place to heal skin and bones. Stage 2 to be done after 6 to 8 weeks when you know for sure that your infection is not there, and that remains the key and the problem, because that's one thing which we are not having objective criteria to ensure that. Once you do that, you see how the membrane is forming inside, which is a biological chamber, not an artificial made, nothing, it's a biological chamber. And then you put in the grafts to get good results. So the final and the most important point to understand for the Masquelet is you do not cure infection just by putting in a cement spacer, as many people do. It's not that cement spacer is going to cure infection for you. What you are going to do is manage the critical bone defects. Infection control depends only and only on debridement, removal of dead bones, soft tissues, increasing the viability and the vascularity, along with antibiotic usage. So Masquelet will, along with the debridement, give you cure of infection. It will enhance the bone formation in a non-infected biological chamber, which you can create in an infective non-union, or if it is an open fracture with a critical bone defect, you can get it present already. Just this case, just to show that yes, it is one of the options, not only which will always fail. Fractures which was having a flap, you can see a small infection, which is how normally it happens, and you do the infection control by removing the dead bone, and you removed the dead bone, had the bone cement with the proper debridement and making a bone defect. See the flaps, it was already there, and that was the reason why it was the vascularity was maintained. Stage 2, you remove it, put in the bone grafts, immediate post-op, 3 months when we start the weight bearing, 6 months, 10 months, 14 months with the patient okay. Yes, there will be some failures, but you need to understand that infection needs to be controlled first, and what sort of bone defect are you managing with it. Another case, having an infection with a non-union, multiple times, interventions done 7 times before. We removed it, put in an antibiotic nail, removed the bones which were there, put in the antibiotic spacer out there. Afterwards, when it was okay with us, we went in, put in the bone grafts, and see, we were able to remove it within a complete union. There are various techniques, and if we look at the tips, which I'll just finally tell you, is debridement is the key which you need to understand in any infection for that matter. They are doing it at a Ilizarov corticotomy, but again, they are debriding it, most of the soft tissues and the bones. Neurovascular needs to be prevented and taken care. Cement spacer should be uniform, not overstuffed. Soft tissue reconstruction is very important. The only problem is if you suspect infection after stage 1 at the time of removal of the cement spacer, you remove it, be aggressive, curate the membrane formed, and new debridement should be performed with a new cement spacer. Just don't put in your bone grafts out there. When you do a bone grafting and stabilization, usually you do it at 6 to 8 weeks, especially in femur, it is very effective at around 8 weeks. Tibia takes longer when you are doing in Masquelet. Infection you have to rule out by clinical, biochemical, as well as your observation intraoperatively. Use RIA or your bone substitutes. Instead of a fixator, convert it into a specific definitive fixation as well, which is an added advantage of a nail or a plate, which will help you give good results in Masquelet. I'm just giving you a brief outlook. We'll discuss it in more cases. Remember, it's a promising technique if used properly. If you don't use it properly, it will always fail in your hands. It reduces the ingrowth, graft resorption is reduced, new vascularization is promoted. Significant bone losses up to 10 centimeters can be prevented. The only two concerns which we have to be sure about before using a Masquelet or during the use of Masquelet is how we are controlling the infection and from where are we getting the grafts. If these two things can be managed, Masquelet is one of the best treatments, I would say, for infective gap knowledge.
Thank you. Our next speaker is again going to speak about how the Ilizarov Ring fixator is useful in a infected gap Nounion. Dr. Ajit.
Yes, good afternoon everyone. So I'll be discussing Ilizarov, a time-tested device in treatment of gap non-unions. So multiple ways to treat it. I'll be discussing upon the Ilizarov. So she is a 66-year-old female who had grade 3B fracture distal third of the tibia with bone loss, which was managed initially with the external fixator and cross leg flap. And these are her clinical pictures about 2 months after the separation of the flap. Still the wounds are not very well healed, as you can see. So we planned Ilizarov for her, a 3-ring construct, not to open the fracture site, span the ankle and do a percutaneous tibial osteotomy for the bone transport. These are her X-rays, clinical pictures, and these are the serial bone transport X-rays. In the lateral view, clinical pictures during the bone transport. And these are her X-ray films after the docking. All the 4 views, well-healed wound. And as the transport fragment docked into the distal, we allowed her to walk with weight bearing as tolerated. So as we waited the regenerate to heal, we found some lacunae in the regenerate, for which we planned bone grafting. And these are the X-rays after the fixator removal, 3 months post bone grafting. There was one complication of ankle arthrodesis in this case because she was having some infection around the ankle. Due to the stabilization of with the Ilizarov frame, her ankle got fused. These are this is a walking video after fixator removal. Clinical pictures, and this is her 3-year follow-up X-ray, her gait after 3 years. Her function. So this is a second case who's a 20-year-old male who had around 8 to 9 surgeries before coming to us. He presented with a small discharging sinus. He had grade 3B fracture of the proximal third tibia. You can see the amount of soft tissue injuries which he sustained during the trauma and a lost piece of bone which was kept on the X-ray cassette. So probably we went into history and he was treated with a Masquelet. You can see there is some resorption of the bone grafts in the X-ray. The previous X-rays with Masquelet are not available. So again we planned for dissection of the flap, debridement as there is a continuous discharging sinus since many days, opening up of the medullary canals, and 3-ring construct, distal tibial osteotomy for the bone transport. These are her pictures during debridement. You can see a large piece of sequestrum over there. We just came out with a simple osteotome. So after debridement, these were the bone pieces which were removed, and he ended up in having such a long defect. So we went ahead with the bone transport in the AP view, in the lateral view. His wounds healed very well. The regenerate was well forming, but his fragment was colliding posteriorly in the lateral view, as you can see. And there was only point contact over there. So we shifted him to ortho SUV and made plan 1 of correction of the translation. And this is how we corrected his translation and made plan 2 of telescoping and docking. So this is after the execution of plan 2. You can see there is a telescoping of the bone fragments. His gait during that phase with the hexapod fixator on. After the work was done, the struts were changed to straight rods. His clinical pictures showing completely healed wounds, clean pain tracks. His well-healed fracture and regenerate in all the 4 views. And this is his 2 years follow-up X-ray. His gait at 2 years. His function and range at ankle, knee range of motion. So the Ilizarov is a well-known modality for the management of infected gap non-unions. It has advantage of getting a good hold in small osteoporotic bone fragments. It allows early mobilization. The frame application should be stress-free for straight trajectory of the bone transport fragment. Thank you.
So I invite Dr. Arvind Goregaonkar for his presentation.
The most important point in treating the infected gap non-union is to get the infection under control. Now, a simple fracture can land up in a very difficult situation, and see what happens. This was a patient, 24-year-old male, due to traffic accident. There was no compounding and there was no distal neurological deficit. Common operation, interlocking nail done. Everybody is happy by this time. This is what happens. Patient came 4 months later. You find that there is clear-cut infection. The bone is already, destruction of the bone is already taken place. Plus, there is a persistent discharging sinus. At this stage, I want from the faculty to find out what can be done at this stage. Anybody?
Basically, there is an infection with sequestrum.
Yeah.
So, implant should be removed, the sequestrectomy should be done. I would prefer Ilizarov with bone grafting and acute docking plus supracondylar osteotomy for lengthening with Ilizarov.
If you look at the picture, you will find the whole medullary cavity, not only at the fracture site, all along, is infected. Look at the distal screws, which are already loose. So, would you like to do any osteotomy at this stage?
It requires thorough debridement first, over-reaming of the medullary canal. Of course, the implants come out, and then maybe a temporary fixator initially with a cement block and mobilization of the patient. And maybe you can do a Ilizarov after the infection settles down.
Yes?
What is the organism?
Method, I think, yeah. So what we had, one second, I will just tell you. See, what we did is, at this stage we decided that since the whole medullary canal is involved, we should go for the cement, antibiotic cemented nail. And this is after opening at the fracture site, you can see the bone is completely dead. That portion of the bone we need to excise. And interlocking nail with the maintaining the gap. That is how it was done. 2 months later, by this time, when we have send a sample, we didn't get any growth, and therefore we were not able to, because many times the patient remains on antibiotic and then difficult to get the growth and what organism it is. But the cement was used with the vancomycin and tobramycin, cemented nail. So after 2 months, we thought it will come under control, but it did not happen that. If you look at it after 2 months, the whole shaft was again infected. You can see there is more infection at the fracture site, and the discharging sinus again started discharging. So it has worsened by this time, and there was something else to do. See, can you tell us what can be done at this stage?
I think you will have to take out the intramedullary implant at this stage. Clear out the medullary cavity. I will not hesitate to put antibiotic mixed spacer there with LRS or some. I won't use an Ilizarov in this patient. It's too high for that. I will probably go for removal of implant, medullary clearance, antibiotic cement spacer, and an LRS. That will be the combination.
Yeah. So basically good development
Delayed bone
and stability. So this is the nail which was removed. We put the LRS fixator and put the spacer. So that is cement spacer. Again, we tried to maintain that gap because we didn't want any shortening eventually. And fixator was holding well. 2 months later, we found a sinus had healed by that time. ESR was 20, CRP is 2, and patient was clinically looking not an infected type of patient. Skin was comfortable at that time. Pain was not there, and then we decided to do something to bridge that gap. What can be done for bridging the gap? Ajay?
I just want to know one thing first. Right, after putting cement spacer and LRS, why did you wait for 2 months? Usually the membrane that is formed is most active at the end of 1 month. And by 2 months, the activity goes down. So the effectivity of putting bone grafts later on becomes more and more, less and less successful.
Maybe there's some reason why we could not do that at that stage. But when patient presented to us, it was already infection which was in a active situation. So the grafting, bone spacer and LRS. Now what? Dr. Mukhi?
Giving me the chance, and I must know what is the buck. If
Yes.
I cannot catch the buck, then you have to use all the 3 antibiotics and put this antibiotic in the cement spacer after the bubbles are over.
Yeah.
Otherwise, these heat-resistant antibiotics, they don't lute out first. So the tip is that don't mix the antibiotic
At the
first.
beginning.
After the bubbles, you mix.
Yes.
That is the technique tip. And then when the infection is controlled and you have got the membrane 2 months, you put antibiotics in that graft also. Papinicolaou's method. He used to put the 3 millimeter bone grafts and antibiotic, and it would heal.
So after removal of the cement spacer, you want to put a corticocancellous graft?
Yes, cancellous mostly.
Cancellous mostly, and continue with the fixator.
Yeah, not more than 3 millimeter plants.
And continue with the fixator?
Or with the antibiotic coated plate inside, because he's fed up with the fixator.
Well, what we did is we removed the spacer, got a fibula and a cancellous graft from the iliac crest. They are packed together and use a implant, which is a plate, trochanteric plate with the screws. And because the area was completely normal, therefore we thought this is probably going to work. So this was the immediate post-op X-ray. Yeah, here the cement bead was not added at this stage. So what do you think is the future of this? Dr. Herode?
I think what you have done is correct. The only problem is the fibula should hypertrophy. So I have seen a few cases who have come to me. A plate was applied, it was of the tibia. So 2 plates were applied and a fibula was put to bridge that gap. And the patient came for removal of implant. And after that, few days after that, when he started walking, the fibula fractured. So
Yeah, that's a tibialization of the fibula. The fibula get hypertrophy as you start wet bearing.
So the fibula from the opposite side was put intramedullary. It was not transport of the fibula.
So when you put an intramedullary, the loading does not happen. And your case, the 2 plates were supporting for the loading.
No, it was not my case. The patient
What-
came to
whatever
me
case
after
you are talking about.
After the patient, after the fibula fractured, the patient came to me.
But what is going to happen to this now? Any
I
prediction?
suppose it should have united. Maybe that is why you are presenting the case.
So this was 1 year follow-up. After the 1 year, you could find there's a lot of bone formation. Fibula is already incorporated into it. Patient started walking. This was at the end of 2 years. You see the implant, there's no loosening of the implant and the bone is completely formed. And this is how the patient was walking. So the key is to control the infection first. And if you can do that, healing is not the issue, because at this stage there was some debate whether we should put any internal pleat or still continue with the fixator. But since the local situation was good, we went ahead with the internal fixation and we got, this is the result we got. Thank you.
Thank you, Doctor.
Next, Dr. Herode, please come for the presentation of the case.
Dr. Praful.
Yes. Afterward, after the cement is set, almost set in the sense you mix the cement, then vancomycin and then tobramycin.
Dr. Mukhi, somebody makes tobramycin powder. Maharashtra.
Powder is available.
Availability is a problem.
I have some comment.
Yeah, Dr. G.S. Kulkarni, please.
We have done comparative study of muscular technique in the femur and the tibia. And we find that in the tibia, the muscular technique failure rate is very, very high. This is because of the musculature around the tibia is much less and the vascularity of the tibia is less. In the femur, it is on the opposite side. That muscular techniques works very well. And the bone transport has got many complications in femur, especially the knee joint becomes more stiff. So the muscular technique works very well in femur and bone transport works very well in tibia. These are the comments.
Dr. Praful.
Yeah, should I start? Okay, so we'll just discuss a few cases. I am Dr. Praful Herode. Okay, so this is a patient, a 32-year-old male. He came to me with this kind of fixation and it was infected and with a discharging sinus. So there is non-union and there is infection. So what we did is first we removed the implant. The patient was posted. First the plate was removed and we put in these cement beads. The cement beads were kept for a few days and in the next setting we removed the cement beads and put up an Ilizarov fixator. So this is the condition when we put in the Ilizarov. There is some malalignment which was corrected with the help of hinges. So these are the hinges that we do translation and angulation correction. So after that the patient, in all these things, when the patient comes to us right from the cement bead application and after putting Ilizarov, the patient is always weight bearing. Initially some with crutches and then later on as the fracture unites with full weight bearing. So this is the state at 8 weeks. Then at 14 weeks follow-up, this is the X-ray at 14 weeks follow-ups. And then at this stage, when we feel that it has united, patient is full weight bearing, what we do is we loosen the nuts, we do a checking, we admit the patient. And then we loosen the nuts and make the patient walk full weight bearing on that for around 1 or 2 days and then remove the fixator. So this is at removal of fixator. Okay, so with this the patient is full weight bearing, but we still want to protect him with a brace for few days. Because you can see that there is some fracture line is still seen. Okay, so this is the next case is a 29-year-old male comes to me with a comminuted fracture of distal end of tibia. This was the patient on presentation. A fixator was temporarily external fixator was applied initially. This was then converted into Ilizarov. These are the clinical pictures. The patient is walking. After this is the follow-up after 2 months, 5 months follow-up and on removal. Again we are protecting this patient for another maybe 2 weeks, 2 months with a brace. Then this is some interesting case. This is not infected, but just wanted to show. So this is a patient came to me, 39-year-old male patient. He came to me after 1 year. This is the patient who had in the corona times. So he comes to me after 1 year. I don't know where he had been, what treatment was taken, or he probably he couldn't take treatment. So he had a non-union neck femur plus a non-union in the supracondylar region. The screws were put, these are the older ones. So what we did is after a lot of discussion, we did a total hip replacement in the proximally at the neck side, and the patient was mobilized on a plaster. And after few months, we put an Ilizarov here. Again the patient is weight bearing on the Ilizarov. And then this is at 4 months follow-up, and this is the follow-up on removal. The full length X-ray show that the mechanical axis is well aligned. This is another case, last case. This patient came to me with this much tibia is not there. He was initially plated, it went into infection, the plate was removed, and then he has come with a gap non-union of such there is nothing here. So when we decided to do this case, we were doing corticotomy at 2 levels. While putting wires in his foot was so flail that we could just pass wires with my hand without using a drill. With the wires were going directly with hand. So I was not very sure whether I should be doing this case. But then since we are working in a medical college, all the patients are very poor. They can't afford very high-fi treatment or treatment out in a big setup. So this is what is done after that. Corticotomy we started distracting. This is 1 month follow-up. This is again 3 months follow-up. Follow-up after 6 months, good bone formation is seen. Although there is some deformity, but good bone formation. After few days, this is 9 month follow-up. Now we have done bone grafting at the ankle side. We opened at the ankle side. We removed all the soft tissues that were invaginating inside and removed the cartilage and bone grafted. The patient is still undergoing treatment. This is the way he is walking with so this is the longest, the patient who has kept the fixator for a very long time. It's almost 2 years now. Thank you. Yes, sir.
So the total hip head
Yes, sir.
which you removed, you should have taken that head and used as a graft distally.
Right. So we try to find out. So this is a combination of a arthroplasty and an Ilizarov. So Ilizarov is an external fixator. There are very high chances of infection. So we took some opinions, we tried to search for in the literature of something like that. So after how many days it is safe to put an Ilizarov fixator?
Yeah.
And I didn't get any answer. So, 1 second, sir, I'll answer your question. So we did the Ilizarov almost after 6 months after we have done the totally.
Right. So you can put that head in the iliac crest. That's what Charlie used to do. He used to put that head in the iliac fossa.
Yeah, maybe.
And after 2 years, 3 years, when they required revision, that was for that, he used to take out that head and use it as a graft.
Yeah, that is one option.
Yes, Dr. Bukhi, yeah, that was correct.
Yeah.
Could have been done.
Don't throw away the head.
Any question?
Any more questions? Thank you.
Thank you, Dr. Herode. May I call upon Dr. Suhas Shah to do his presentation?
Good evening. It's an infected gap Nounion and unconquered fortress. As you know, infection burns in the fire of the regenerate, the famous sentence of Ilizarov. What are the problems? Usually we have got a scarring of the soft tissue, there is atrophy, there is infection, necrotic bone, sometimes osteomyelitis. As Dr. Bukhi was talking about, there is an organism which are resistant to the most of the antibiotics. There might be some deformity, limb length discrepancies associated with this. Joint stiffness is there. There is a disuse osteoporosis or associated neurovascular problems. The distraction osteogenesis attempts to address all the problems simultaneously. So, with infected non-union with a gap, my preferred plan is freshening of the edges, excision of the necrotic and osteomyelitic bone, and this is most important, that debridement should be proper. And I prefer acute docking. What is the advantage of acute docking? It helps to reduce the union time, the treatment time, but that requires expertise. Acute docking can be done from hand to elbow or knee to foot to the knee also. But you have to know the vascularity, the Doppler should be there in the operation theatre, and you should see after docking that the vessels are not compromised. Then I preferred osteoperitoneal flaps, corticocancellous chips, bone grafting, and definitely a corticotomy is the most important part in this treatment. Like this is the infected non-union, this is the positioning, we preferred internal iliac crest. Fibular osteotomy is important because we are trying to do acute docking. Then this incision S shape is important because in acute docking, if you take a vertical incision, it becomes diamond. And if you take a S-shape incision, then it is easy to close the skin. Then there is always intervening fibrous tissue which requires excision of the bone ends, proper medullary canal rimming, and osteoperitoneal flap raising, which is also very important. And then I use a temporary fixation with a plate, which is removed before removal of putting the Ilizarov, after putting the Ilizarov, and I prefer corticocancellous chips grafts with a cortex facing to the bone and cancellous force facing to the muscle. Then closure, then fixation with a fixator, and final is the corticotomy and removal of the plate and compression. And this is the way you can get a very good alignment with using plate and bone grafts and corticotomy, which helps to control the infection. Whenever there is a big defect, you might use intramedullary graft, as you seen the previous speaker showing the intramedullary grafts good result. It improves the stability and it reduces the treatment time. Union not achieved after 6 to 7 months with the Ilizarov technique, you have to change the plan, and sometimes you get a stiffness at the non-union side, which you can utilize by distracting the non-union and get a good result. So this is a case of infected non-union in child. She had osteomyelitis, and I prefer to ship the fibula as a vascular graft inside the gap and use that non-union stiff at the upper third of the fibula as a distraction osteogenesis technique and lengthen the leg and united the non-union also. And this is the final result. She came like this and she had such a good result. So in summary, distraction osteogenesis helps early weight bearing, dynamization and correction of the deformities in any plane possible. Frame construct can be modified, acute docking, corticotomy, lengthening, always possible. So this is the Ilizarov fixator helps to achieve good results in infected non-unions, simultaneously addressing all the problems. MIMT is an effective method, but you should know the entry of second surgery 6 to 8 weeks, and after achieving stable mechanical environmental necessity also important, but there is a union healing rate is 86% by first second surgery, where distraction osteogenesis has got 95%. So more research needed to discover and understand even the most basic aspects of MIMT success, and more importantly its failures. So take home messages behind every successful treated infected gap non-union is a distraction osteosynthesis or Masquelet technique for an improved functional outcome. Both MT and IVT DO can be a good treatment for segmental bone defects. How to improve the healing rate of infected bone defect, shorten the period of treatment, and prevent the relapse of infection is still worth pondering. Thank you.
Thank you, Dr. Shah.
Any questions to the panelists?
Has anybody tried visualization of the fibula with your own thing? Because if you fail, then at least that fibula, which is fused up and down, it gives good stability.
Yes, Dr. Mukhi, we have cases, but because of short of time, I'm not able to show you. I have cases which are where we have used fibula, like an old Huntington procedure we used to use, or something similar to that to bridge the gap.
Very good result.
I think the time is over. We invite for next session. Thanks a lot for all
Thank you very
the
much.
speakers.
Thank you very much to all the panelists, chairperson, and the audience. Thank you.